I'm going to concentrate more on the total knee arthroplasty because the total hip, to be honest, we don't rehab anymore. They get them going very early, and the only time we really see a total hip is if they've had problems prior to the total hip surgery to get them going. So I needed to put up this definition. Expert from Merriam-Webster, knowledge derived from experience. So I didn't realize it, but in early January I had my knees x-rayed. I didn't realize that I was getting bull-legged. So that are my knees in early January of this year. On January 30th, I finally had it done. So I'm 3/4 of an inch taller. They feel great. So I've made it through this. I have a little bit more sympathy right now for my total knee patients, but I'm glad I did it. Okay. And by the way, I did all my talks during my recovery. They were highly opioid influenced, and Dr. Bob will be talking about that following this. So in terms of the goal of total knees, again, pain, function, improvement, or range of motion. Not a lot has changed there. And in terms of expectations, most patients expect within 3 months they will be able to have a good functional recovery. In fact, 80% expect several of these activities to be performed. The outliers might be the kneeling, some people even walking that far without an assisted device, but we're seeing these younger patients nowadays, and again, they have very high expectations. So in terms of pain, in a 5-year study, preoperatively, again, almost 100% expected full pain relief, and again, for the most part, people are very satisfied in regards to their pain relief. In terms of range of motion, all protocols are a little different, but this was a study done by Powers in regards to, what is functional range of motion. So I guess the study by Rowe looked at, again, 20 elderly but normal patients looking at functional range of motion. And again, they looked at gait, walking slopes, stairs, standard and low chairs, and getting in and out of a bath. And what they found is that with normal gait, require less than 90 degrees of motion. Stair negotiation or low chairs a little bit more, 90 to 120 degrees. The outlier would be the bathtub, almost 135 degrees is needed there. But the conclusion was at least 110 degrees of knee flexion would seem to be a reasonable goal for total knee arthroplasty. And again, in this study, out of 684 patients, those with knee flexion less than 95 degrees had trouble. And again, we can see from that prior study, they would have difficulty with stairs, and some of those lower chairs. So with these individuals, this was a group of patients they looked at prior to having their knee replaced. And compared to healthy adults, they already had 20 degrees of less active knee flexion, 5 degrees less knee extension. So we start very early in rehab. They start this day 1. In fact, they do prehabilitation now. They are working with the range of motion. We start stretches very early now. And again, a lot of this rehab has not changed. And we are moving them very quickly with their motion, working toward these goals. So our flexion goal by 6 weeks is 115 degrees, 8 weeks, 120 degrees. The bike, we start early. It used to be in my practice, I would say 3 to 4 weeks, we could normally start a bike. We see patients now starting even at 1 week. They're going very early with this. You can cheat on this a little bit with the seat high, putting the heel on the pedal. In terms of extension, again, they're starting very early. The heel prop, long sitting, prone line, and even just stretching the calf. So we're starting very early with these individuals. But here's the big key with range of motion, and as Dr. Dahl talked about, in these studies, if you did not see your motion back by the 12-week mark, you weren't going to get it. So the doc normally sees them back at 6 weeks. We expect 3 or less for extension, 115 degrees more of flexion. At 8 weeks, we'd like to see 0 to 120 degrees. One of the problems, though, with that, the biggest predictor of how well they're going to do with motion is what they had prior to surgery. So sometimes it's nice even to see these individuals prior to surgery to see what they had. So what about manipulation? Well, 90 degrees of flexion was considered as a minimal functional goal for total knee arthroplasty. So this study looked at 143 patients undergoing a manipulation under anesthesia. They did this at 8.5 weeks. And in this group, 95% did very well with it. They averaged 62 degrees before manipulation for knee flexion, and were able to get to 101 degrees. How about strength? One of the things they've seen with studies for people prior to having a knee replacement is they're already weak. In fact, they're almost a third weaker compared to people or peers their same age. So 1 month after surgery, we're already seeing people are 50% weaker. In 6 months, patients are recovering their strength very comparable to what they had before surgery, but remember, they were already a third weaker before surgery. So this was a study that kind of showed that. They basically looked at 40 subjects and followed them preoperatively and then several months. These individuals all had 110 degrees of knee flexion. However, strength was highly correlated in regards to function. So again, quad strength is very important. And again, they are weak before surgery. So we start out very early, and again, rehab has not changed. And we do step-ups, we do wall sits, but we're also using more machines now and getting people into the gym. So balance is another thing. When they do these total knees, they basically whack out everything in regards to our proprioceptors. And in this study, there was, again, 67% less mean single leg stance duration than that of healthy controls. So the recommendation now, besides getting that strength back, working on that proprioception and balance type activities to get these people back to full function. Our rehab right now is very scattered. You know, when you look at protocols, it seems like every facility has their own type of things that they follow. And this is some of the things that they're starting to follow. Mark will go over a little bit more today in regards to what's being done at CHI, but a lot of it is just by trial and error. And right now, what we're doing seems to be working. So the changes that we have made here lately is we do start rehab earlier. It used to be 3 weeks post-surgery. Now we're starting at 2 weeks post-surgery. And again, much better in regards to the patient, but we are getting them going very, very early. And then also, this was a study where they were allowing them to go into a pre-op education program. Well, length of stay actually decreased by a full day. And again, a big thanks to Mark and Colleen and the whole staff at CHI. They're getting these people going very early and educating them. So by the time they see us in the clinic at 2 weeks, these people have been going pretty gung-ho, and they'd have a coach. In terms of prehab, again, a number of studies are showing that, again, it does work for increasing strength and function, but also a 6-week exercise program actually reduced the risk of discharge to a rehab facility. So again, we're getting these people home earlier and quicker. The expectations, though, are still fairly high, and probably one of the things we are missing is going to be the strength and balance part. We seem to be working very well with motion, but are they getting their full strength back? So again, people have very high expectations. The question is how many are actually able to return to those expectations. So in terms of what we're doing, again, we're getting our early range of motion, and that has been very helpful. 110 degrees, that minimal functional goal, but the resistance training and balance training we need to add into our rehab. Thank you.